Dr. Barry Matterson was a widely recognized nephrologist and hypertension researcher. He was the former chair of the VA Cooperative Study Group on antihypertensive agents, and he was an active member of the Joint National Committee for Detection, Evaluation, and Treatment of high blood pressure. He was also, to many of us, he was really a wonderful, gentle, supportive mentor and colleague and friend. He endowed this lectureship in perpetuity to bring leading hypertensive tension experts, such as today's speaker, Dr. William White, to medical grand rounds. In Barry's own words, the purpose of this lecture series is to expose faculty, house staff, and medical students to the prominent hypertension authorities and to provide the opportunity to posit relevant questions. Thank you.
Dr. Rodriguez.
Yes, thank you. So good afternoon, everyone. It's my pleasure today to introduce our grand round speaker, Dr. William White. Dr. White is Professor Emeritus of Medicine at the University of Connecticut School of Medicine, where he served as Chief of the Division of Hypertension and Clinical Pharmacology in the Calhoun Cardiology Center. He also founded and directed the Clinical Trials Unit at the University of Connecticut Health Center in Farmington. He first obtained his medical degree from the Medical College of Georgia and subsequently completed residency training in internal medicine and fellowship training in clinical pharmacology at the University of Connecticut Health Center. Dr. White's research is focused on ambulatory blood pressure monitoring, clinical trials of antihypertensive drugs, and the impact of non-cardiac medications, including analgesics, hormones, NSAIDs, and neuropsychiatric agents in cardiovascular disorders. A nationally and internationally recognized leader in cardiovascular medicine and therapeutics, he has authored more than 400 original articles and 90 book chapters. He's contributed extensively to landmark clinical trials and national hypertension guidelines, and has served as a cardiovascular safety consultant to the U.S. Food and Drug Administration. Please join me in giving a warm welcome to Dr. William White.
Very good. Thank you very much. First, I guess I'll share my screen and hopefully everything will work nicely. Let's see. Here we go. Great. Thanks for this introduction. I'm really pleased to be here today in honor of Barry and also to give this talk related to my own research and that of others in the field of clinical hypertension. I have spent about 45 years in Connecticut, surprisingly to myself, and have had a really great time of it as well, not only locally, but also on the national and international level. I have no disclosures related to this topic, but I wanted to immediately go to this photo. So I spent about 30 years as a member and about 10 years as a board member of the American Society of Hypertension. And that's where I met Barry. Barry was, as Rick just mentioned, Dr. Preston just mentioned, a true gentleman and always willing to help everyone that he came in contact with. And I think we overlapped on the board of directors for about 5 years, and he served, I believe, as secretary treasurer during that time. And then I became the president of the society in 2012 for a couple of years and scientific program chair of several years of meetings. And this was after I was finished with that, and I think he was finished with that. We were just regular members at this point in time and having a nice time in New York City where our annual meetings were held for all 3 or 4 of those decades. Also, I should mention that Murray Epstein.
¿Se pone, por favor, de pecho?
Murray Epstein and Barry Matterson invited me to be a visiting lecturer there at the University of Miami. I think somebody needs to mute. In about 20 years ago. So I had the opportunity to lecture at the University of Miami-Jackson Memorial Grand Rounds, the VA, and do some conferences with fellows. It was a great trip and very collegial. So today we're talking about blood pressure measurement, and we're going to branch out into clinical trials, but just to point out that we have three major types of measurement that we're used to in both practice, but also in research. Clinic, which of course is our easy way we do things. We're all very comfortable with it. It is associated with many decades of clinical trial research, but it does have some issues. First of all, it's not a very reproducible measurement, prone to a lot of problems, which I'll mention in a second. And it also has two phenotypes that are now well defined called white coat hypertension and masked hypertension. Self-monitoring, typically done at home by patients, is, I think, a great way to involve patients in their care, and it empowers them to some extent, makes them more compliant. But it can't be the first line of assessment, in my opinion. It has to be something as an intermediary. It doesn't have nearly the level of outcome data that we have with clinical measurements, 24-hour blood pressure measurements. And the devices are unfortunately somewhat variable depending on what people just find for themselves. Ambulatory blood pressure monitoring is always called ABPM, and it's a way of us getting between 60 and 100 readings over a 24-hour period automatically. The beauty of it is the ability to get nocturnal blood pressures and sleep measurements, and it's also the best way, probably the gold standard way, to evaluate drug treatment effect. Now, it is not the most convenient thing for patients to do repeatedly, and there are some cost issues, which I'll talk about as we go through this. Now, in the clinic, this is something that was put together by a fellow from Finland about 10 years ago. Of all the things that can go wrong with blood pressure measurement in the doctor's office, the cuff can be missized, especially if it's too small. You'll get a much higher reading than you really should be getting. Without having a comfortable back, legs on the floor, and arm basically supported, the readings can also be much higher than they really should be. And that's not to say about the things that occur as well, such as observer bias and rounding to zero and things of that nature that happen, all the time with clinical blood pressure measurements. So this is a joke slide, but it is in fact correct that these are the kinds of units that people could wear nowadays, in which they have a device that has a motor compressor on it that weighs under a pound now. There's one of them is Space Labs, the other one is Suntech. They're the two biggest types of units in the United States, but there are many others out there, including in Europe. They basically do not interfere too much with activities of daily life. I always told patients not to wear these things if they were planning to go to the gym for an hour or two, because that kind of motion really drives these oscillometric devices crazy. And people who drive in vehicles and anything other than highway driving also can get into some trouble with artifact. But besides that, they really work very nicely for getting activities of daily life, night, day, sleep, awake. This is the kind of profile that one might get or output graphically on the left and in a tabular form on the right, where we can see the time that they got hooked up here, a little bit of a pressor effect, the daytime values, the shaded areas when they're sleeping, and then the waking when they wake up again and they're active. Here you see this particular individual happens to be a normotensive with an average value of 131/83. And you can also determine how many measurements were made at the various times, including the awake period and the sleep period and so forth. Well, there was a lot of controversy about what should be considered the upper limits of normal for ambulatory blood pressure, because it's always a bit lower than the clinical measurements. And a fellow from Cornell and I, who were close colleagues and friends for a long time, Tom Pickering, created this particular table in one of our review articles many years back. And these still pretty much are the same as they were in 2008. You optimally want to have a daytime value less than 130/80 and a 24-hour less than 125/75 to be considered normotensive on an ambulatory blood pressure monitor, and should have a nocturnal decline, which I will go into depth about momentarily. So I'd like to start out with a case so you don't get too bored. And these are real patients I'm going to show you. This is a person with what I call white coat effect, because she was definitely diagnosed as hypertension hypertensive and was on drugs, 65 years old, and her blood pressure's in the clinic, average 162 over 88, taking maximal doses of hydrochlorothiazide, amlodipine, and the ARB olmesartan. And she said, I am not going to go on any more medicines because my blood pressure at home, and she showed me a 2-week chart, average 126 over 84. And she didn't really have too much going on, from a clinical perspective. Good kidney function, normal ECG, a little arterial or narrowing on a retinal exam. And here is her 24-hour values, 118 over 74. Awake, 128 over 80. Nice decline in blood pressure when she's sleeping. So what's one to do with somebody like this? An interesting problem, and it's not uncommon. So I'll first show you some historic data on outcomes in people like this patient. This is actually one of innumerable studies from the IDACO database, this international database of ambulatory blood pressure as it relates to cardiovascular events such as MI, stroke, and CV death. It was put together originally by investigators in Leuven, Belgium, Jan Stayson and his colleagues, but many people got involved with this. I think they had up to 15 countries and about 20,000 patients by the time they stopped doing the work. This particular analysis was by Stan Franklin, who was at the NHLBI and had about 15, 16 years of follow-up. And the white coat hypertensives, like I described with that patient, and the normotensives show pretty much the same cardiovascular outcome, despite the fact that they're not taking antihypertensive medications. Whereas those with sustained hypertension and what we'll soon define as mass hypertension had a significantly higher event rate. And here are the data for those who were taking antihypertensives, even more strikingly similar for the white coat hypertensives and the normotensives and the sustained and the mass hypertension. Nice separation that occurred within a couple of years after they started this cohort follow-up of about 6,500 people. Now, there was then a lot of people who like to do systematic reviews and meta-analyses, and this one was put together by Daiichi Shimbo, who's at Columbia, and Paul Muntner, who's a superb statistician at the University of Alabama, Birmingham. And they reported that while some of the studies showed very comparable event rates to a normotensive, that's what these odds ratio or hazard ratios are, and certainly very different for sustained hypertension. Some studies were showing a significant increase. One in particular, the largest one actually, was this Spanish registry by Benegas et al., published in the New England Journal of 2018. And there was a lot of speculation about this study at the time it was published, and many people were writing into the journal about its statistical authenticity. And lo and behold, the authors retracted the article, stating, quote unquote, that there were analytical database and data analyses issues. So we are going to have to discount that biggest study in that particular analysis. So going back to my patient, what would you perhaps consider doing? You could add a fourth antihypertensive drug. She didn't want that, but you're the doctor. You can maintain what she's taking and reassess her with ambulatory blood pressure in 1 to 2 years, or you could continue her home monitoring and then decide if you want to do ambulatory blood pressure if her home blood pressure has changed. So I'm going to show you, I'm going to tell you that I did B, but I'm going to show you something that happened after I saw her, and that is this next study from an old friend of mine from north central Italy named Paolo Verdecchia, who had been following about 6,000 middle-aged to older age Italians who had either normotension or what he called ambulatory hypertension or white coat hypertension, and he looked at stroke rates. Now, I want to point out that this population did not have fastidious control of their cholesterol, great control, glycemic control of type 2 diabetes, and there was a much higher proportion of people who smoked. in this group than you would have seen in the United States. It was about 35%. And that's extremely high. Even back then, it was about half that here. But you'll look at the event rates for stroke event rates. So at 6 years, it was about 2% for the normotensives. At 10 years, it was about 3%. Then we look at we look at the ambulatory hypertensives, as he called them, and it was about 4%, so double that of the normotensives at 6 years, and also about 6%, about double at 10 years. And the thing that bothered me and many other people was what happened with his white coat hypertensive cohort. During the first 6 years, the white coat hypertensive cohort looked just like the normotensives. And this is after 6 years. And then there was this transition between years 6 and 10 or 12, where they started looking more and more like the ambulatory hypertensives. So keeping this in mind, what do you think happened here? Well, I think what happened is that not all, but some of these patients transitioned from white coat hypertension to a more sustained hypertension status. They had been left untreated and they started developing more complications. So in fact, it's probably okay with somebody like the patient I just showed you. You never know what's going to happen to her, to follow her closely, but you cannot say to any patient, you have white coat hypertension, you have nothing to worry about, because sooner or later, individual patients might transition and might have risk. So I'd like to now talk a little bit about, in section 2 of this talk, about nocturnal blood pressure, which happens to be really important in clinical practice and clinical patients. So patients who have high nocturnal blood pressures are typically those who have a lot else wrong with them, particularly patients with diabetes who have neuropathies, people who are salt sensitive, such as African American patients, individuals who have sleep disordered breathing, such as obstructive sleep apnea, and those patients with kidney disease and salt sensitivity as well. This was a landmark study done in clinical hypertension about 30 years ago, which actually had a control group and a treatment group. We had one in the United States called the Systolic Hypertension in the Elderly program, or SHEP. This one was the SYSTUR program, which was the counterpart that was done in Europe with the same design. Patients were taken into the study with isolated systolic hypertension and treated with a placebo or a diuretic, and you could add to the diuretic a beta blocker, keeping in mind this was 1980s, 1990s practice. But what I'm pointing out here has nothing to do with that trial, but what happened in the placebo group based on different kinds of blood pressure measurement. These are 2-year outcomes for mostly stroke and heart failure. And this yellow line depicts the clinical measurements. And you'll notice that people between 160 and 220 had a fairly modest grade of events. But in the green line, these were the 24-hour values obtained at night. And they showed a much steeper relationship between systolic blood pressure obtained with a monitor and the cardiovascular event rate. This was pretty much the first study that demonstrated the importance of nocturnal blood pressure and cardiovascular events in 1999. So now let me tell you about another patient of mine. He was a 73-year-old man who owned his own company. He was still working. He was extremely sharp. And he had a nice looking blood pressure of 134/74 in the afternoon on hydrochlorothiazide, valsartan, and long-acting nifedipine. He was quite concerned because he was fastidiously measuring his blood pressure in the morning and getting 180/100, and he was really quite concerned. He brought in his readings. He looked like he knew what he was doing. He was getting lower values in the afternoon at work. He didn't have a completely normal exam. He was overweight. He had some AV narrowing and nicking, a fourth heart sound, a little edema, tall R waves consistent with probable LV hypertrophy. So we put a monitor on this patient, and his 24-hour mean was actually hypertensive. But the most interesting thing is that from hours 18 to 24 on the study, he was like a significantly more hypertensive than at any other times of the day. And this did coincide with about the times he was taking his own readings. So what could we do in this individual? Well, I mean, one option is we can increase his medications, maybe add a fourth one at bedtime, maybe add a fourth one in the morning. So those are definitely possibilities, and we'll talk more about what I ended up doing with him after we look a little bit at some data. There's a picture of him, if any of you recognize him. He was very famous at the time. Probably only a few people know this is Vice President Richard Cheney. Anyway, what does this? What makes somebody have a blood pressure that looks good in the office setting and high out of the office, so-called masked hypertension? Well, actually, these people have a negative white coat effect. They feel very comfortable in the medical care environment. They like their doctor. They like their APRNs or PAs. They're resting. They don't have any sympathetic nervous system stimulation to speak of. Then they leave that environment and they go to home or work to an environment that's more stressful, with more physical activity, with more mental activity. Perhaps they smoke cigarettes and get the effects of nicotine. Perhaps they drink a lot of caffeinated beverages throughout the day. These are various things that can happen, or perhaps they have nocturnal hypertension, like my patient, who was overweight and more severely systolically hypertensive. So these are the things that one has to consider. So going back in the early years of the definitions of masked hypertension, again, the group from Cornell, Dr. Pickering and colleagues, he did move to Columbia later on, but he was at Cornell at this time, defined people as true normotensives, masked hypertension, and true hypertension based on the differences between their clinical blood pressures and their ambulatory pressures. And then he did a survey of carotid disease using carotid intimal medial thickening as an outcome, and left ventricular mass index using echocardiography at the time to determine if they had LVH or not. And it was quite remarkable. Those who had the same, pretty much almost the same clinical blood pressures, but a higher ambulatory blood pressure, had a target organ assessment that looked much more like those with true hypertension. So this was the original findings here, and then subsequently outcome studies have demonstrated that patients with masked hypertension do in fact look much more like those with sustained hypertension in the office than those who are normotensive. And to make a point of this, and I've drawn a line through that study that got retracted, in this case, those patients with masked hypertension in this pooled analysis of many studies involving several thousand people have about a doubling of cardiovascular outcomes events such as MI, stroke, and death compared to those with normotension. Okay, before I go to that next slide. So what I did in that patient, this number of years ago, he had prostatism, and we were not using that much in the way of chronotherapy, which I'll talk about in a moment. So I put him on a pretty decent sized dose of doxazosin, an alpha blocker that he took at bedtime. And then we repeated his 24-hour blood pressure study, and he both had great relief from his prostatic symptoms and a normalization of his early morning blood pressure. So he was happy with that, and I was at the same time. Okay, so now I'm going to shift gears a little bit and talk about a field that's related to this whole business of ambulatory blood pressure, because ambulatory blood pressure really measures the circadian variation of blood pressure over the day and night. And there is this field in physiology known as chronobiology, and it's not new. It's been around since the 19th century, where people began to notice that certain diseases and disorders had a cycle to it that was different from one time of the day to the next, or maybe one season to the next, and so forth. For example, cortisol has a circadian variation, right? So it's high in the morning and lower in the afternoon. And it can turn out that some people have asthma attacks more commonly in the different times of day because of cortisol levels that are endogenous. Blood pressure, heart rate, all go up in the early morning when people first wake up from a rather low level. And at those times of day, there's a much greater frequency of cardiovascular events, including sudden death, ischemic cardiac disorders, ischemic stroke, and so forth. So I was starting to do research in 24-hour blood pressure and target organ involvement in I would say, yeah, the mid 1980s. And I was a young, assistant professor. And there was a medical student that on one of my ward services that I was required to do, whose name was Julia Hallberg. And she was actually from Minnesota. I'm telling the group about my work that I was starting to do, and she got very excited and told me that her father, and she was not holding back, was the father of modern chronobiology, a professor who had emigrated from Hungary and was now at the University of Minnesota, and his name was Franz Hallberg. So I thought that's very interesting. I don't know anything about that. And then I was sitting in my office several months later, and my phone rings, and I get this call from Franz Hallberg, who identifies himself and has this extremely thick Slavic accent. And he says to me, Professor White, I understand your research is coming along very well, and I'm going to invite you to be our plenary speaker at the International Society of Chronobiology. Well, for a young guy, with 20 publications, I was pretty excited. I said, Professor Hallberg, so where's the meeting going to be? And I'm thinking Prague, Budapest, Rome, I don't know. He goes, Little Rock, Arkansas. And I went, Little Rock, Arkansas? He goes, cheap space. So I said, okay, I'm happy to help. I fly to Little Rock, Arkansas. I give a talk to about 300 people, and I look at their research, and they want me to give them advice. I noticed that many of their studies had an N of 5 or 6 people, and the N comprised of their brother, their daughter, their wife, and so forth. And I said, that's not good. And I started thinking about IRBs and human ethics committees and so forth. And so they said, well, what would you do? Because we want to become more well-known in our field of medicine. We're physiologists and biologists, but we want to be more medically accepted. So I said, well, the first thing you have to do is get larger sample sizes. And I'm sorry, but you got to stop putting the people who work for you and your family members in your studies. It just doesn't look good. So they were nodding their heads and everything was looking good. I felt like I had done something quite helpful and important to this group. They were the kindest people, serious scientists, but they lacked substance with regards to those things. So fast forward about 4 years, and I am now on sabbatical in the cardiology center in Bergen, Norway. I was doing work with a fellow named Per Lund Johansen, who was a famous invasive hemodynamicist. And I spent about 15 months with him. And during that time, I had an invitation to chair a section of a cardiovascular meeting in Italy, in Rome. And as I'm going in, I'm checking into the hotel, and it's early in the morning, and I see Professor Hallberg, his wife, and his 2 daughters checking in as well, and they're all wearing 24-hour blood pressure monitors, checking into the hotel registration desk. So I say hello to them, and I go over, I pull aside the daughter, who, is my former medical student. Now she was a resident in medicine at University of Minnesota. I said, what's with the monitor? She says, oh, it's another one of Dad's experiments. I said, what's the experiment? She says, it's the 4 of us doing 24-hour blood pressure monitoring every day to assess the seasonal variation in Minnesota. I said, you're wearing those every day for 1 year? She goes, yeah. I said, that's rough. She goes, we've been doing about 5 months and we're getting used to it. She said, it's way better than last year's experiment. I said, what was that? She goes, the seasonal variation of rectal temperature. So anyway, you can imagine that not much had happened from my little speech at the International Society of Chronobiology. Okay, so moving forward, there is some really interesting things that happen at night that has led to characterization of different phenotypes of blood pressure. A riser, somebody who actually goes from night to day, and their blood pressure is actually higher at night than they are during the daytime. This is bad. This is like autonomic abnormalities. A non-dipper, somebody who doesn't decline at least 10% when they're sleeping. A dipper, somebody who does decline by about 10 to 20%. And this particular individual is the bulk of most people with hypertension and normal tension, about 75%. And then there's a few people who go down really quite dramatically by 20, 30, 40%, called extreme dippers. They sleep well with a monitor. It's a small percentage, but they don't do badly at all. And then there are these different things that occur that increase blood pressure at night episodically, like sleep apnea. It's an amazing thing to see an ambulatory blood pressure profile in somebody with obstructive sleep apnea, because as soon as they finish the apneic period and have the snoring and choking and all that, their blood pressure goes up by about 30 or 40 millimeters of mercury. And if this happens with an AHI, apnea hypopnea index, of let's say 30, 40, or 50, it's really substantial during the night. So, and there's studies that show that CPAP and surgery for OSA alleviates this completely. So I wanted to point out a study that was done at the beginning of this century by Dr. Cario from Japan. He was a fellow of Dr. Pickering's and moved back, and he's become a chairman of medicine in one of his own institutions. He's a very prolific researcher, and he actually accumulated I think it was about 500 hypertensive patients and characterized them as those with a morning blood pressure surge, where the difference between the morning blood pressure and the pre-awakening blood pressure was at least 20 millimeters or higher. And so in that particular cohort, he then followed them up with MRIs of the brain and also prospective information over a few years. I think it was 3 or 4 years, and demonstrated that those people who had this uncontrolled morning surge compared to those who lacked it had a greater chance of having both silent ischemic infarcts of the brain and also developing a clinical stroke prospectively in the future by 19 versus 7.3%. So this was early evidence that having this uncontrolled increase in blood pressure when you least know it, when you're first waking up, is hazardous. Hence, the patient I just presented to you was at an increased risk of this until we alleviated that with a nighttime dose of medication. So this is a segue to my own research, which I would like to talk to you about just for a couple, 3 minutes. So I got involved with the chairman of neurology at my place about 20 years ago, and we were funded by 2 substantial R01s from the NIH, NIA, and NHLBI that looked at the relationship between different kinds of blood pressure, other cardiovascular risk factors, and white matter hyperintensity lesions. And we actually would acquire a T2 flare image of the brain as shown here. And you see these little white spots that are around the ventricles of the brain. These are areas not that are infarcted, but actually have very low blood flow due to small vessel disease. And we collaborated with a very well-known group in radiology at the Brigham for most of these 15 years. And they had a program where they segmented these lesions and were able to quantify the percent of damage compared to the whole brain and model them like this. So you get these beautiful images of where the white matter lesions were in pink, the ventricular fluid in blue, and then other normal tissue surrounding it. And you can see this is one particular patient who was looked at baseline without any particular intervention and then followed up 2 to 3 years later. Actually, I think it was 2 years later, showing this significant accumulation of this white matter disease over that time. These were all people who were over 75, by the way. So I had done the risk factor assessments in this population, and we did find that there was a really remarkable relationship using these low S spline curves between changes in 24-hour blood pressure over 2 years and the development of the changes in the white matter lesions accumulating, whereas we did not see this relationship with clinical blood pressure. So with these data as kind of so-called preliminary data, even though it was a massive NIH grant, I created a clinical trial also with funding from the NIH called Infinity. And in this study, we randomized patients who were over 75 with no upper limit to a blood pressure on the ambulatory recording of 130 versus leaving them at 145. Now you might say, well, that sounds unethical, but this was a number of years ago. And at this point in time, there was no evidence that in an older population averaging in their 80s, that getting lower than 145 was in fact beneficial. So we were looking at the functional parameters such as mobility, cognitive function, as well as the accrual of these white matter hyperintensity lesions on MRI. And we also looked at other things like syncope, cardiovascular events, and so forth. So here's the design. We had 300 patients who were either randomized to this intensive arm or the standard arm. They came in on therapy or off therapy. They had to have a elevated 24-hour blood pressure and clinic blood pressure. And I spent about 2 or 3 years recruiting and enrolling patients because it was a single site study. So pretty much all I did in the mornings for several years. And those patients who got randomized to 130 were typically on one more medication than those who got randomized to 145. We would do more clinical and ambulatory blood pressure measurements over about a quarterly visit and adjust their drugs as needed. So we did a good job, actually. They came in to the study ranging about 148 to 151, and over the course of where they achieved goal to 18 months to 36 months of follow-up, they pretty much stayed about 145, 146 versus 130, 132. And as you can, I said 300, it was actually 200 patients in this study. It's 300 in the other one. And then we looked at the changes from baseline to the end of the study in white matter hypertensity, and it was significantly lower in the intensive group versus the standard. We didn't suspect that we could regress this, by the way. This is damage that is done. The idea was whether or not you could prevent the continued development of small vessel disease. Unfortunately, we did not see any changes in mobility between the two groups at 3 years, but we did see improvement in some of the cognitive parameters in people who got intensive blood pressure control. And then we did a sort of a sensitivity analysis for those who always stayed at their targeted level and showed that the magnitude of change in white matter disease was actually even lower in those who were intensive versus standard of care levels. One interesting thing that came out, and this was not a primary endpoint, but non-fatal cardiovascular events adjudicated to be MI, strokes, heart failure, or arrhythmia were significantly lower in those who received intensive treatment versus those who received standard treatment. But other things such as falls, syncope, falls without injury, etc., were not any greater in those who were treated intensively. Now, some of you may or may not be familiar with the SPRINT study. The SPRINT study started after this study, actually, but did demonstrate a very comparable finding, although they had a big sample size and they were younger than my group of patients. Mine averaged about 81, 82 years old, and the fall rates and the syncope rates were higher in patients on intensive treatment. This is one of my patients from back in those days. His name was Fred. He was a mechanical engineer. It was an unbelievable story. He comes in because he wants to be in the trial. He lives in assisted living 3 miles down the road, and he drove during a snowstorm in his new Nissan. And I looked at him and I said, "I'm sorry, Fred, you can't drive anymore in the snow, maybe not at all." And he got very upset with me, but he says, "I'll still be in the study." And he did, and he continued for the next 3 years. He made it to the age of 100 in my trial. He was randomized to the intensive group. He had virtually no white matter progression, and he was sharp as could be at the age of 100. I went to his 100-year-old birthday party, and I kept in touch with him. He did pass away at the age of 103 in his sleep. I mean, it just doesn't get much better than that. Okay, the last section of this talk is about therapy. And I'm not going to talk about a lot of things that you might think. I'm not going to show you one drug trial after another. I'm going to show drug trials that have a learning tool, a learning part to it. But basically speaking, ambulatory blood pressure monitoring is in fact the gold standard of the way we assess medications after the time of dosing, its influence on circadian variation, and it's very important because it removes all or most observer bias in clinical trials. So the first one I'm going to show you is a study that I did together with Dr. Preston. And this was actually a remarkable finding. This was a study that involved almost 800 women who were postmenopausal, and we were assessing a new progestin called drospirenone, which could be taken in combination with estradiol for postmenopausal women who were symptomatic. And the reason that we were studying this is because it had an anti-aldosterone-like effect, and we thought it actually might actually lower blood pressure because, as many of you probably know, at the time of menopause, blood pressure starts to rise, HDL cholesterol starts to fall, total cholesterol starts to rise, and we end up with a increased cardiovascular risk in that kind of population. So it made a lot of sense. So this is actually data from that study. By the way, it lowers blood pressure, but this is data just in the placebo group. And on the left-hand side are the changes in 146 patients on clinic blood pressure. Went from 151 over 94, dropped 8.7 over 5 on placebo. The ambulatory blood pressure was lower, as it typically is, 137 over 83, because it's got the effects of sleep. But here, the systolic blood pressure change was only 1, and there was almost no change in diastolic. So what's going on here? We have almost a 9 millimeter reduction on placebo. And this had a terrible effect on what was the placebo subtracted findings on the drospirenone, because it lowered about 10 or 12, so it looked like it did nothing, although it did look better versus on the ambulatory. So I said to the statistician, I want to do a treatment by country and a treatment by center as assessment. And he said, that's a ridiculous waste of time. He says, the study is what it is. He says, there's no problems. We did this all over the world, and this is the finding. I said, there's something wrong here. I don't know what it is, but you've got to do that assessment for me. I had to talk to his boss, actually, and he told him to do it. And lo and behold, at one center where there was 44 patients enrolled in Russia, everybody, I mean, everybody in that study had a 40 millimeter or greater reduction in blood pressure, no matter what they were treated with. And their ambulatory blood pressure, which he was blinded to, was not that high. It was very modest. So what we learned later was that the system in those days is that sites in Eastern Europe insisted on getting paid as an honorarium for study patients. The more you had in, the more you got paid. If you keep people in the study, keep them happy, then they're going to stay in the study. And this was fraud. And this is the way we determined there was fraud in our trial. It caused a lot of problems, but this unfortunately happens, and this is the way we learned that it happened. Here's a second study. Many of you are familiar that there's been about 2 decades of research on renal denervation with a special catheters. Medtronic makes one that's actually on the market. But this is prior to all of that. This is where investigators like Felix Mahfoud from Germany was publishing superb work on his center's findings in patients up to 346 with resistant hypertension. And here he's showing the changes in office blood pressure after renal denervation in people who are on 3 or more oral antihypertensive drugs, showing that in those with true hypertension, they are going down about 21 over 9 after 3 months, 24 over 9 after 6 months, and 27 over 12 after a year. And the pseudo-resistant people are individuals who actually didn't have hypertension on the monitor, just in the office. So that was a much smaller sample. Here's the findings with ambulatory values. The reduction was now only about 9 or 10 over 5, not 20 over 12. And those patients who had hypertension only in the office, or white coat hypertension, if you want to call it that, had no changes whatsoever. So all the studies with renal denervation had the same problem, and it became evident to the FDA. So the primary endpoint had to change in all these trials to changes in 24-hour. And I will tell you that in untreated patients, renal denervation only causes about a 7 or 8 millimeter reduction in systolic blood pressure. It is actually not any better than a single monotherapy drug. The last clinical trial slide, I want to show you is this particular study of nocturnal dosing of a long-acting diltiazem, only to illustrate that if I had this at the time of my patient, the man with the nocturnal, the rise in blood pressure during the morning, this might have been a nice idea for him. In white, the white squares are the untreated time for this guy randomized to diltiazem LA. He's given the dose at night, and here's from midnight to 4 a.m. to 8 a.m. In the black squares, excuse me, you see this really impressive reduction in blood pressure. This is diastolic, but it was the same for systolic. Here's a morning dose of ramipril in the blue circle showing a much more modest reduction, but still a reduction in blood pressure. So that would have been another option had it been available at the time. So I'm going to do a little bragging. It's going to be only for a minute, but 23 years ago, I got a call from one of the senior editors at the New England Journal and said, we see you're doing work in this field of blood pressure monitoring, and we think it's timely to have an editorial review on this for our journal. So I was just me, and I decided, well, what do we know? We don't have any outcome data at that point in time, but we have a lot of target organ data, and I was part of that. I was doing that work, and I had my own experience with thousands of people I'd already monitored by 2003. So I just stuck my neck out, and I made a decision that 130/80 is the goal value we want. So you're hypertensive, you come in, first you do a few weeks of self-monitoring. If you're less than 130/80, then you do a 24-hour monitor. If you're still less than 130/80 on the monitor, non-drug therapy, but make sure you repeat the ambulatory pressure every year or two. I just knew that people could change. If you're higher than that, you initiate antihypertensive therapy, and you might want to follow them up once or twice to make sure they're well controlled. In addition, I was willing to say if you're self-monitored and you're greater than 130/80, you probably should just initiate antihypertensive therapy. And this is with or without other comorbidities. So I was getting ready to get creamed by people all over the world saying, you can't say things like this. There's not enough information. I didn't hear anything from anybody for the next year or two. And then amazingly, moving forward, like almost 20 years, the U.S. Preventive Services Task Force, who are extremely conservative, said that people who have white coat hypertension should get an ambulatory blood pressure monitor. We were amazed. The American Society of Hypertension and the Heart Association was amazed. Then the guidelines that have come out from Europe in 2023, the ACC/AH guidelines in 25, all now give ABPM as a level 1 or level 2 evidence for assessment of hypertension to improve CV risk profiling and to identify phenotypes such as white coat hypertension and mass hypertension. They also stated, by the way, it could be used to diagnose true resistant hypertension, but unfortunately, that is not covered by any insurance companies. In fact, right now, if you have a patient who you want to just confirm a diagnosis of hypertension, or you want to evaluate to see if they do or don't have white coat hypertension or mass hypertension, it will be covered by most insurers, including Medicare. But if you want to evaluate to see if they have treatment resistance or labile values and a lot of variability, or correlate their symptoms with blood pressure, they're not going to pay for that. And if Medicare won't pay, then your other private carriers probably won't either. It'll be out of pocket. So I would like to say I really appreciate getting invited today on behalf of the late Dr. Matterson, and thank Dr. Preston for thinking of me and your entire group for having me present this grand rounds today. And I am now delighted to entertain any questions that anybody would like to ask.
Thank you, Dr. White, for that very interesting and important Grand Rounds lecture. Let me begin by asking perhaps the first question. I mean, the technology seems to have advanced a bit to cuffless blood pressure monitoring. And the truth is, with remote patient monitoring being so much a part of the EMR, and the ability to have patients comply with writing down what their blood pressures are, or even in the ambulatory machines that are currently available. Today, you can just buy an Apple Watch or a Ring and get your blood pressure. And I know they haven't been validated, But what do you think in the next 2 or 3 years is going to really be the way in which we can assess ambulatory blood pressure monitoring?
Oh, this is good. That's fine. So there is one company, BioBeat. I have nothing to do with them. I'm not a consultant, but they have a sensor that can be worn on the chest or on the arm that is cuffless, and they are approved for external blood pressure measurement by the FDA. They passed what's known as a 510(k) validation study, and that is now being evaluated by the vendors that do ambulatory monitoring for clinical trials. It may very well be in a couple of years that they will be available for that kind of thing. As well as far as ambulatory blood pressure labs converting at this point in time, I don't think that's happened yet, but certainly the validity of them are improving. The problem has always been that they don't, they use plethysmography as their primary method of assessment, and they are prone to motion artifact. So I think it was a very smart idea to put it on people's chest walls almost like an ECG device, because there's less movement that there would be with the arm. So I think it is a real possibility that they could be used. They're not being utilized right now in clinical research formally, but that day could change.
We actually do have, for those primary care and cardiologists in our audience, we do have BioBeat availability here at the University of Miami. And I see Dr. Delgado has anxiously unmuted herself. So I imagine she has.
I'm unmuted, yeah. So, Dr. William, it's such a pleasure to listen to you. And from my standpoint, and I'm going to take just 1 or 2 minutes to hear somebody talking about hypertension other than myself is something extraordinary. But we do have the first American Heart Hypertension Center here at the University of Miami, the first one in Florida.
Right.
And we have implemented, first we did the ABPM as it is currently, like the cufflet, but then we implemented towards the ABPM cufflets, and we have done over 4,000 across all insurance. So to your point, data is what you get. You understand what nocturnal hypertension is, what is circadian behavior, sympathetic tone, and extraordinary because changed the way you phenotypically see hypertension as a disease that is systemic, that lives with you on day-to-day basis. So it's not just one pill and one algorithm and you're done. So it really has been a pleasure listening to you, to see somebody talking more than me about hypertension.
I used to get a lot of blowback, in the earlier years about this because nobody wanted to abandon their office measurement, and it was a struggle for a long time. But the proof was showing them the graphs of their own patients, and we served as like you're talking about, as a sort of a central lab for physicians in our region, not just where we work, but we had private practitioners and doctors from other hospitals ordering our service because they didn't want to invest in it and the time, and you have to train people to do it right. And so those were all things that we worked out over time, and I had a lot of grateful doctors that found the information very useful.
Dr. Preston, you unmuted yourself. Do you have a question?
Yes, thank you for great grand rounds, clinically based and very informative. Thank you, Bill.
Sure.
In looking at one of the practical aspects, do you find that patients being woken up by the cuff affects the measurement of the nocturnal blood pressure at all, or is that something you can factor in or adjust for? Does that clinically present a problem for you?
It does in some patients. I mean, there's no doubt that sleep quality is affected by these, and depending on the individuals who wear it. I mean, I would say that it affects about 10% of the patient population in clinical practice. A much lesser number of people who involve themselves in studies because they sort of self-select that they're going to be able to tolerate it.
Yeah.
It's a very tough thing to answer the question about what happens when you awaken repeatedly to your blood pressure. I mean, it should go up, but of interest is that I had patients tell me on their diaries or the next morning that they were up every hour on the hour, and I saw a completely flat
Wow.
nocturnal blood pressure that demonstrated no evidence of a pressor effect from their waking up at all. So, they might have felt themselves getting up, but it was not maybe during that reading, and they might have been up for a minute or two, and it didn't have any effect on the 15-minute average. In the old days, I used to do these studies where they got inflations 4 times an hour for 24 hours a day. Then I lightened to about 3 and then even to 2, so they wouldn't get awakened too much. But I think globally speaking, in a cohort of patients, the nocturnal blood pressure is the most stable value of all the ambulatory data that you get. But in an individual patient, it could be different.
We have a question in the chat by Elias Selepis. Do you want to ask your question?
Yeah, hi, Dr. White. Thank you for this great talk. I'm an endocrinologist, so my question is, before they said screen for primary hyperaldo, adrenal adenoma, obesity, sleep apnea, young age, family history. But nowadays we're seeing a lot of undiagnosed cases of either primary hyperaldo per se, or the spectrum of low renin hypertension. What's your take? And also, there was this question amongst primary care physicians, which medicine should I hold patients on
Well, there's a lot of questions.
Yeah.
There's a lot of questions in there, Elias. Let's just stick with the.
Okay.
Right. So my
this
question was,
yeah.
sorry for the prelude. So should it be more widely implemented and more of kind of what's your take as far as testing most patients for hyperaldo? Thank you.
I'm big on that. Actually, I we were very aggressive about checking for primary hyperaldo in our practice, but of course we were more of a referral practice. We got a lot of severe hypertensives, people who were refractory to therapy, and I mean it's like 1 out of 4 of our patients had hyperaldo. But now the guidelines from the ACC and AHA are probably very in line with the endocrine society's recommendations to check at least one value in all newly diagnosed hypertensives, because the rate of it is at least 10% in the hypertensive population, and it's an unfortunate thing to miss, and therefore and on top of that, I mean it's not right now, but I mean very soon there's going to be a new class of medicines on the market called aldosterone synthase inhibitors. There's 2 companies which are going to be probably approved by the end of this year, and they directly target the enzyme that creates aldo. They are very selective, so they don't block cortisol synthase and cause that problem of inhibiting the steroid metabolism, and they end up causing a really nice reduction in blood pressure in people with hyperaldosteronism, and are better tolerated than mineralocorticoid receptor blockers like Clarinone and spironolactone. They still will cause the same hyperkalemia, however, in people who have reduced GFRs that you see with the MRAs, but in people who are hyperaldo, they'll preserve potassium very nicely. So I would say yes. I mean, and I actually was in a discussion with the person who wrote this section for the AHA-ACC guidelines in 2025. Her name is Jordana Cohen from Penn, and she had done an extremely thorough assessment of the cost benefit of doing aldo levels in not just people who you suspect, but in all hypertensives, particularly when they're not on drugs which will interfere with the assays,
Well, thank you very much, Dr. White. I know Dr. Matterson is smiling from above at the wonderfulness of this particular lecture. I want to remind everybody to check the chat for the link for CME and MOC, and remind everybody that next week we will return to our hybrid Grand Rounds format. So please come in person to the Rosenstiel 3rd floor auditorium. And I wish everybody a great day. Take care of yourselves and take care of each other. Have a good one. Thank you, Dr.
Bye
White.
now. Thank you so much.
Thank you, Dr. White. Great to see you.
Bye. Yeah.